Hi, I'm Ted Morton, clinical pharmacy specialist at St. Jude Children's Research Hospital in Memphis, Tennessee. And I'd like to thank you for what you are already doing to promote antimicrobial stewardship in pediatric patients with sepsis. I hope our talk today will help emphasize all the things that you're already doing to ensure antibiotic use is appropriate and achieves optimal outcomes, but then give you ideas for new areas that you may be able to expand into. So we're going to start by going over the mandate for antimicrobial stewardship. And we'll talk about the strategies and interventions that are used in antimicrobial stewardship, many of which may sound familiar to you because they're actually being used at your home institution. These are things that can be hardwired into the care process, including guidelines and order sentences. They may be active interventions that occur during the hospital course as more data become available, things like prospective audit with feedback, antibiotic timeouts. And then we're going to wrap up with key strategies for success. And I'd like to state that I have no conflicts of interest to disclose relevant to this presentation. Antimicrobial stewardship aims to optimize the short-term and long-term outcomes and consequences of antibiotic use. And in pediatric sepsis, we are acutely aware that the short-term goal is to get immediate empiric antibiotic therapy that is adequate, both in terms of spectrum and dose, given to a patient who we suspect an infection is causing their systemic inflammatory response and their target organ damage. We also would think long-term downstream, especially as more data comes available and we may be able to optimize or refine or de-escalate our therapy about the outcomes and long-term consequences of antibiotic use in that individual patient in terms of adverse effects, Clostridial difficile colitis, and potentially selection of resistant organisms in that patient, and then the overall ecology of our healthcare system in terms of antibiotic resistance. We recognize AMR is a global threat. We do not have an adequate pipeline of new drugs, and all these things make antimicrobial stewardship absolutely critical, both empiric therapy, appropriateness, and then downstream de-escalating or optimizing whenever we can. Because of this mandate, there are a number of organizations here within the United States, the Centers for Disease Control and Prevention, quality metrics, including U.S. News and World Report, and then accreditation organizations like the Joint Commission, all of which spell out elements of stewardship that are needed in healthcare institutions, what those elements are, and they are organizations are held accountable to that. But we must not lose sight that at the end of the day, it's the individual patient and patient populations we serve that need us to be good stewards of our antibiotics. There are specific strategies for stewardship that are endorsed by the Infectious Disease Society of America based on scientific literature. One of the two of the key components are pre-authorization, often referred to as formulary restriction, and then prospective audit with feedback. And we'll go into those strategies in a little bit more detail. But those are the most strongly recommended approaches. There's also a strategy called an antibiotic timeout, and it's implemented with a philosophy of handshake stewardship, of working in partnership between ID and stewardship with the primary services to collaborate and make decisions together to improve the antibiotic use. And that is now considered a leading practice by the Joint Commission and other organizations. So not as much evidence, but a direction we need to go. And we'll go into the details of what those antibiotic timeouts look like a little bit later on. So when we think about a patient who presents with non-specific findings consistent with sepsis, fever, target organ damage in terms of classically hypotension, perhaps a focus of infection, we need to think about the initial question of, does this patient have infection that requires antibiotic? In the setting of sepsis, if that is a diagnosis, the answer is absolutely yes. They also need fluid resuscitation. They may need vasopressors, but antibiotics are part of that initial treatment for pediatric sepsis. We need to think about trying to get appropriate cultures before starting antibiotics whenever possible, still respecting that very tight window. Usually it's framed within 1 hour to get appropriately broad and adequately dosed antibiotics into that patient. And the empiric therapy, it should not be a one-size-fits-all. We'll talk about strategies to optimize those initial antibiotics that reflect practices of stewardship, local epidemiology, and patient-specific risk factors. those are the initial management. And I think that probably sounds very familiar to those of you practicing in critical care. What also should sound familiar is what happens 24, 48, 72 hours later when we have more data and we have opportunity to step back and say, can we stop the antibiotics? We have a diagnosis now that clarifies what those presenting symptoms were caused by. Can we change them item to oral? Can I narrow therapy? Can I define the duration of antibiotics? And that duration question is really one of the most important things in terms of long-term selection for antibiotic resistance, that longer durations are more likely to contribute to resistance developing. But we can frame these decision points in terms of our intervention stewardship to the initial impaired order, and those are the hardwired elements, and then things downstream in the clinical care, which are well suited for active interventions. And in daily practice here, what we've done is hardwired guidelines, order sets, and sentences, and our approach to formulary restrictions, which tends to be more prescribing restricted to ID, but can also be pre-authorization. And then also some alerts for drug-resistant organism history, if relevant. And those are our hardwired elements. And then our active interventions at the 24, 40, 72-hour mark are where we do our prospective audit with feedback. That's where we have a active antibiotic timeout process. And then also we have elements where our clinical pharmacists are able to make some significant interventions. Now, one element also to emphasize is diagnostic stewardship comes into play. Not diagnostic stewardship, not in terms of which diagnostic tests are ordered. That's going to be more in the hardwired element, but more leveraging microbiologic data that has become available to allow for either escalation, de-escalation, discontinuation, or duration. But that's where that microbiologic data can be employed. All right, so how do we hardwire stewardship for pediatric sepsis through guidelines, order sets, and order sentences? Well, it's most helpful for the appropriate empiric therapy. What you don't want to do is take an international guideline and cut and paste it into your care process. It needs to be individualized to your institution to reflect not just the current literature, but your local susceptibility data. What bugs do you have, which cause, say, for example, bacteremia? And then which antibiotics are they usually susceptible to? And what is that rate of susceptibility? And then incorporating principles of stewardship where particularly risk stratification can be very, very helpful to give a more nuanced approach to which antibiotics to use empirically. And I'll explain that a little bit more. But here I have an example of an antibiogram from our institution. We know which gram-negative rods are most likely to be isolated from blood, hence the ones likely to cause sepsis. And we know which antibacterials are going to be active against them, and percentage-wise, which ones are going to be our best choices. Now, we can then have those be incorporated into a guideline that, for example, in febrile neutropenia, we may start empirically with cefepime as our workhorse for patients with febrile neutropenia. But if you see that they have sepsis, or they have chills and rigors or sepsis, then for our guideline, that would be a patient we would initially start actually with broader spectrum gram-negative coverage to include ESBLs and so forth with meropenem, or potentially alternatively add amikacin. Meropenem monotherapy or cefepime with amikacin in our institution has about the same, almost 100% activity against most gram-negative rods, but that's been put in our guidelines. And we have criteria for when you would add vancomycin. But what we do is incorporate these guidelines into order sets and order sentences where guidance on when to use broader spectrum agents would be clearly stated in the medical record. So, for example, here, if they have intra-abdominal complaints, we would recommend adding metronidazole, and it would be prompted when you go to enter the orders in our sepsis order set to consider that as a patient-specific risk factor of abdominal pain for anaerobic pathogens that would require a different agent than our typical cefepime monotherapy. Could we build those in? Now, if you are in a paper electronic medical record or paper medical record, you might use order forms for sepsis that have these options spelled out and the criteria for use. But these are all ways to incorporate stewardship into your initial enteric therapy. I mentioned dosing. In sepsis, you would want to make sure, especially if they're being fluid resuscitated, they may have an altered volume distribution. You want to give adequate doses. And so we built into our electronic medical record our dosing. We do it in milligram per meter squared. You can do the same thing in milligram per kilogram, but specific for sepsis with maximal dosing, appropriate priorities for administration being stat, and then we capture indications so that downstream we can be able to evaluate very quickly, was this an appropriate indication for this particular anti-infective? So when our providers have a pediatric patient with sepsis and they're going through this process, they're being good stewards because they're choosing appropriate antibiotic dosing for that specific indication. But we've built that in to make it easy to do the right thing on the front end. Now, pre-authorization and formulary restriction needs to be handled very, very carefully. We do not want to have delays in administration of antibiotics, particularly in pediatric sepsis. So implementation of pre-authorization for specific restricted antibiotics usually only allows for dispensing after an early review by an ID fellow, pharmacist, someone like that. In your institution, if you have this, you must have a provision for medicine to be given quickly in medical emergencies like sepsis. So in 24-hour on call, perhaps the first dose unrestricted, followed by review. Essentially, we've restricted prescribing of certain niche antibiotics that are not going to be part of our usual sepsis management, but that prescribing is restricted to infectious disease conditions. They're still available on call, but that's the approach that we've taken with pre-authorization, is just restricting only very niche antibiotics like piperacillin, for us, piperacillin, tazobactam, daptomycin. We also try to build in alerts that would remind providers if they pass in medical history of a multi-drug resistant pathogen that would further necessitate an alternative therapy from our standard guideline-driven care. So this is patient individualization. So at the point of order entry, a alert pops up saying, hey, when that antibiotic is ordered and they have a multi-drug resistant pathogen history, they get an alert that tells them this patient has a history of steno, need to add trimsulfa, they've got a history of carbapenem-resistant gram-negative, might need something else, ceftaz-avi in our case, or other multi-drug resistant gram-negative pathogens. But those alerts help individualize those initial antibiotic therapy to make sure upfront therapy is as appropriately broad as necessary. Downstream, then, the active interventions we might use include prospective audit with feedback. We do this with meropenem and linezolid. Your institution may choose to do something else. But this is at 24, 48 hours afterwards, where our infectious disease fellows will review cases of patients who are on these agents, evaluate appropriateness against institutional guidelines, and then give feedback to the providers to say, hey, great, you're doing the right thing. We completely agree with your use of meropenem for this ESBL. Or they may say, well, now we have more data, we can de-escalate to cefepime, something along those lines. But we capture those metrics, and we review those monthly, and we found this strategy to be extremely effective, and we require a response to the teeth from the primary service when ongoing therapy is not what is recommended or an intervention is needed. And we've used prospective audit with feedback over the past 10 years to help drive our rates of meropenem use down. Now, we still use meropenem up front, but our duration of meropenem has been reduced, and that reduces our overall days of therapy. And that's coincided not just with prospective audit with feedback, but some other strategies to help make sure appropriate use of meropenem happens up front, but then it's stopped or de-escalated as soon as we have the data to support that action. And that helps us reduce the selection for carbapenem-resistant Enterobacterales. Now, I mentioned antibiotic timeout. That is a pause to say, can we adjust or optimize our therapy? And anyone can do a timeout. This is not restricted to ID. It's not restricted to pharmacists. The primary services at our hospital do this a lot. But they simply ask the question, what's the plan for the antibiotics in the ICU? As you go through your problem list each day, just simply asking this question can allow for perhaps escalation or continuation of therapy. We do that maybe 15 to 20% of the time at that 48-hour mark for us. And that means that we're concerned about optimizing therapy, not just restricting antibiotics. But then the other, 85, 90% of the time, 85, 80% of the time, we are able to put them on a defined course of therapy, de-escalate, stop the antibiotics altogether, convert from IV to oral, or even we often change prophylaxis because we are a pediatric oncology center. So that brings us to the strategy of how to leverage diagnostic stewardship. Now, if you're practicing in a institution that has some of the new rapid diagnostic tests, those are fantastic for providing data earlier about the organism, the microbiologic detection, what is the bug, and antimicrobial susceptibility, AST. Most institutions probably have Vitec or Microscan, some other conventional tests, and that really provides data a little bit later, after 48 hours. But regardless, it's important to think about when will I be getting back identification and susceptibility data within this time frame, and then how might that impact our antibiotic regimen. So at our institution, if we have a T2, that rapid diagnostic test will identify a Pseudomonas aeruginosa or Staph aureus. If those are positive and the patient is not on adequate anti-Pseudomonas coverage or adequate MRSA coverage, and those tests are positive, we will know to escalate. And that can be, it's incredibly important if we didn't include adequate coverage on the front end because the patient did not appear to have risk factors for those specific pathogens. ePlex rapid diagnostic test, we find them extremely useful when they detect a CTXM. We will use those results to escalate from cefepime up to a carbapenem-based therapy to cover for an ESBL. Since in the United States, CTXM is the most common ESBL enzyme, we'll use accelerated rapid diagnostic to get an initial identification of the organism of up to 9 gram-negative rods. We can get some gram-negative susceptibility testing for a limited panel of antibiotics, but that can at least give us an alert that we may not have adequate initial empiric therapy and that we need to escalate. And then really our gold standard are Vitec or Microscan conventional testing. But again, that's going to be at 48 to 72 hours. We identify a much wider range of gram-negative rods and gram-positive. And then we can get 34 gram-negative antibiotics, 24 gram-positive antibiotics, those results back, and then switch hopefully to definitive therapy. So here's some examples in real time of how these test results come back. So very quickly, something is growing. Our CTXM is detected. I've highlighted those there. A couple hours later, our accelerator is able to identify by KNA fish, yes, it's in fact E. coli, so we now know we have an ESBL. And then 24 hours later, we have our initial susceptibility results that confirm a cefepime-resistant phenotype with that ESBL. All that being said, if we had CTXM that was positive, we would make sure they are on a carbapenem. We wouldn't wait for those accelerated results to come back before escalating our therapy. So those are just some of the different strategies that we employ over the course of care for a pediatric patient with sepsis, but there's some key strategies to success. And one of the most important for us is a multidisciplinary team approach, and that is administratively in our antimicrobial stewardship team, when we develop these guidelines, when we craft the interventions and decide when we're going to implement them and who's going to implement them. We also work multidisciplinary in the course of clinical care. We have multidisciplinary team rounds. We have the intensivists. We have the ID consult service. We have clinical pharmacists. We have many institutions have plate rounds with the microbiology lab. But administratively, there are many key players that are essential to the success administratively of a stewardship program. And then, as I've emphasized, those there must be local adaptation to your circumstances. You need to consider, obviously, the epidemiology and patient population, which I alluded to. Local resources. Institutions may not have strong pharmacy presence, but they will certainly have nurses and empowering nurses at the bedside to have an antibiotic timeout or pause at 24, 48 hours is a very effective way to start stewardship, even if you don't have a formal clinical pharmacist in that role. Or staff pharmacists could also help serve in that role. If you don't have the resources, then that helps it can help create the business case for why additional resources are needed. So I hope in conclusion that we reaffirmed how essential antimicrobial stewardship is for children with sepsis, and that it's not just possible, that it's essential. It's essential to make sure we have appropriately broad and appropriately dosed initial empiric therapy, and that we de-escalate or refine or optimize therapy downstream as more data becomes available. And that there are multiple strategies that can be hardwired into our clinical care and active interventions that will also help us in our stewardship activities. You're not doing this alone, so there are a number of resources available from the Infectious Disease Society of America, Centers for Disease Control, Prevention, and the World Health Organization, specifically for those low and middle income countries. I'm very fond of there's the guidelines for stewardship in pediatrics, and there's a fantastic statement about the need for stewardship in pediatric oncology that was recently published. I think you could replace pediatric oncology with pediatric critical care, and the same principles would apply, because it's a high risk population that you often feel you may not be able to be steward with, but it is in fact absolutely necessary. So with that, I'd like to thank you for your time. I hope this has given you some ideas of where you might take your program next in your activities. And I'd simply like to thank our Antimicrobial Use and Improvement Committee here at St. Jude. As you can see, very multidisciplinary and very collaborative. And that again is a key to success with these programs and strategies. Thank you very much.